Greetings, Gus T Renegade and Justice in for another edition of the C.O.W.S radio program, hopefully to provide constructive information to help replace racism with justice. Thank you, everybody, for tuning into the program. Thank you all, the cows, according to the people at Blog Talk Radio. Number 2 ranked educational program at Blog Talk Radio. Thank you for supporting. Before we get started with today's program, I want to say happy birthday, Christy Graham. Hope you are having an enjoyable day, and if you are checking out the program, I hope it is of some value. Today's program, if you've been following the cows, Dorothy Roberts, professor at Northwestern University, she was on the show a few weeks back, and I was asking her, could you recommend some other folks who've done constructive research on how racism impacts health, and she said sure. She recommended Vernelia Randall, University of Dayton. She was on the show a few weeks ago. She also recommended our guest for today's program, and Professor Roberts said the person who has done the most and best research, our guest for today's show. I am thrilled to have her on the program. I've been reading some of her different articles. She's been doing research on racism and health for many years now, and she is extraordinarily well informed. She is a professor at Harvard's School of Public Health. Real privilege to have her with us today, Dr. Nancy Krieger. Dr. Krieger, are you with us?
Yes, I am.
Outstanding. Could you please share with our listeners who might not be informed about your work, just let them know a little bit more about who you are and the work that you do?
Sure. First, I'm delighted to be on your show, and I'm very glad that there is a show like yours that's very much devoted to exploring the different ways that racism harms people's lives and also how it can be addressed and rectified. So that's sort of starting point. I'm a social epidemiologist, and what that means is that I'm someone who looks at how it is that the way our society works ends up affecting people's health and causes social disparities in health, causes black-white differences in mortality rates, causes other kinds of injustices in health, and that making it clear that these kinds of patterns of health that we see, where some people do better and some people do worse, is not a matter just of individual luck or fate, but actually has very much to do with how our society is structured and what its power relations are and the ways in which people are able to live and work. So what I do as an epidemiologist is I study these patterns of health in populations and try to understand what causes them. And because I'm concerned about social disparities in health, one of the things that I've been looking at for some time now has been questions of the many different ways in which racism can harm health, and also evidence that when society makes a concerted effort to change social relations and to change injustice, that actually health inequities can shrink.
Outstanding. Before we get started, I definitely want to concede. I think anyone who's been listening to the program, they can attest to the fact I am not Ivy League material. I have noted it is very important for non-white people. A lot of times it's very helpful if people that we're talking to, if they can lower their vocabulary a little bit for us so that we can really grasp everything that you're saying, because you have a lot of extraordinary information, and I want to make sure that we get the most out of your time on the program today. So I might ask you to explain things if I think we don't understand, just to be helpful for us so we can really get more bang for our buck today.
Absolutely, because scientists, we learn to speak in certain language that's not always as accessible, even though it's meant to be informative. So any way that I can clarify any points, I'm happy to do so.
Thank you. I appreciate that. Before we get started, I wanted to just make sure you are a white person. Is that correct?
This is correct.
Okay, just checking. This program, the C.O.W.S, Context of White Supremacy, I'm a non-white person. I have unfortunately concluded that we are in a global system of racism, white supremacy, and the definition that I use for both racism and white supremacy is a global system of people who classify themselves as white and are dedicated to abusing and or subjugating everyone in the known universe whom they classify as not white. Do you believe that such a system exists, and do you think that is an accurate definition for that system?
I think there are definitely lots of systems of power relations that are inequitable, that are unfair, that are unjust, in which one group benefits from exploiting and oppressing others. I think white supremacy is one part of that. I don't think that it's necessarily the whole of that. I think there have also been situations, you can look at some different Asian countries where different groups subjugate each other in ways that I think involve racism, but not necessarily white supremacy. So I think that the issues of racism extend long and deep in global history. And I think that white supremacy has a particular niche to play in that's been particularly powerful and destructive. But I wouldn't want to reduce all racism to a question only of white supremacy. And I also would want to bring in other aspects of domination that matter in terms of economic domination that can happen within racial ethnic groups, not only among whites, but also within other groups as well. So I think, to me, it's very important to look at the connections of systems of injustice, where one group basically does better precisely because it has other people doing worse.
Okay. I definitely concur that there's a lot of mistreatment. You have non-white people mistreating other non-white people, which has also been going on for a long time as well. But I do think it's important, at least for me, I think it's important, and I have concluded that by far the dominant system on the planet right now is the system of white supremacy, where white people dominate the people that they say are not white worldwide. Do you think that's true?
I think that's true, and I would want to link it to the economic systems as well. I don't see these as standing apart.
I agree. I think the only thing I would say is that I have concluded that the white people who practice white supremacy control the economic systems worldwide as well. Some people don't think that's true. Do you think that's true, that the white people who practice white supremacy also control and dominate the economic systems worldwide?
In some ways, yes. In other ways, again, it depends how you're talking about the different expressions of white supremacy. I think there are groups where they actually partly go with an ideology because they don't have resources, and then the ones that do have the resources actually do not consciously think that they're promoting white supremacy. So, I mean, I think we can look at what just happened recently in the United Kingdom when they allowed the British National Party to get interviewed on the BBC. And the base of that party are not people who themselves control the economic institutions in the UK, and the people who do control the economic institutions in the UK are horrified by the positions taken by the British National Party because they are so virulently racist and violent. And so I think that it's important just keeping in mind that the ideology of white supremacy does justify many, many things, but that it needs to be looked at in all its complexities as well as in its brutality.
Okay. Groovy. My co-host, she is a non-white female, and she is all of 10 years old, but she does understand that we do have a system of racism, white supremacy, and she's also here. She would like to ask some questions so she can get a better understanding of how to work against this so we can quickly get to Justice. Justice, are you there?
Huh?
Yes, ma'am. We can hear you. If you have some questions for Dr. Krieger, go right ahead.
What do you do when you are around white people who practice racism and white supremacy?
I couldn't quite hear your question. Was it what do I do when I'm around white people who practice white supremacy?
Racism, white supremacy, yes.
If it's something that happens in my presence, I oppose it. I call it as such, and I mean, it depends on the context. If it's an interpersonal situation, then I deal with the interpersonal interaction. If it's a kind of statement that I feel is problematic, where people are, for example, in the case of health research, only talking about what they consider to be genetic causes and don't deal with social context, then I bring in social context. So how I deal depends on the way in which the views are being expressed and what the context is, but I never let it go unacknowledged and unchallenged.
Thank you.
You're welcome.
How does the system of white supremacy harm non-white people directly and indirectly?
That's a very large question, and I think what would be helpful for me is to move the discussion specifically to the area in which I do work, which is about how racism harms health. And I'm happy to answer questions that are directly about that, but I think that just having a more general discussion is not the best way I can contribute to this conversation.
Okay. That'll be all for now.
Okay. I will get very specific so that we can get to your area of expertise. I wanted to segue because the program that we did yesterday, we spent about 3 hours talking about racism in film. And I read your report, racial discrimination and blood pressure. And one of the paragraphs that I found just startling. It says that results suggest that elevated blood pressure was associated with racial discrimination at work, exposure to movie scenes depicting angry and racist confrontations, and internalized responses to racial discrimination and unfair treatment. According to what I just read, is that accurate, that just observing racism on television, movies, that has an impact on your health, just as if you were mistreated directly or experienced real racism in your life?
I was referring to were studies that have been done by colleagues. I have not done these studies, where there are psychologists who have, in controlled situations in their labs, shown people different kinds of video clips that they put together. Some of the video clips have angry encounters between people, but the encounters don't have a racial edge to them. So it may be that people are mad and yelling at each other, but there's nothing that's ostensibly racial involved in the incident. Versus other kinds of incidents which show also angry encounters, but that do involve a racial incident. For example, a white cop pulling a black driver over on the street for allegedly speeding and giving that person a hard time, a form of racial harassment. And what these kinds of studies have shown repeatedly is that there is a greater blood pressure reactivity. The blood pressure goes up higher for the scenes that are angry and racial as compared to the elevations that you see with the scenes that are angry. So angry scenes do elicit a response, but angry scenes that are also have a racial overtone to them or are explicitly racist provoke more of a response. Now, it's an open question and not resolved about whether these kinds of laboratory scenarios where you're showing somebody something and their blood pressure goes up for that moment and then comes back down again, whether that has long-term health effects is not known. But it's suggestive that these kinds of upsetting encounters, particularly ones that have a racial edge to them, can get you to be stimulated repeatedly to have episodes of elevated blood pressure. And a continued question in the field is whether those kinds of experiences can translate ultimately long-term into having sustained high blood pressure. So you can't go directly from a short laboratory experiment to saying you've shown what's happening in real life, in real health. What's actually happening now is that there are people who are doing what are called ambulatory studies, where they fix blood pressure monitors to people all day and other kind of monitors, and also have them record in a notebook or call telephones at regular times to say what's happening to them during the day. And then they're able to look at what people's real-life experiences are in terms of the experiences that they report, as well as what their body is saying in terms of their blood pressure or other kinds of measurements that are taken. And that kind of work is just being done now so that it can begin to move from a controlled laboratory setting to trying to understand better what actually happens in real life. I haven't seen results of those studies published yet in terms of explicit analysis about encounters of racial discrimination and what that means, for example, for your blood pressure or other measures. But I do know that those kinds of studies are being done right now, and that presumably in the next few years, results should be published.
Wow. I want to be clear for our listeners to make sure I understood that you did not do these studies yourself, but the results that you have looked at, you cannot draw a conclusion or causation, but the evidence might suggest that being exposed to an angry confrontation with racism could have an adverse impact on blood pressure. Is that an accurate summation of what you said?
Almost. I haven't done the video studies. I have not done the video studies. I have done other studies in which I do ask people about what their experiences have been and relate that to their blood pressure and other health measures. So whenever you do a study on a given topic, you always need to read the literature that's on the related topics to see if the evidence is consistent across them. So it matters, for example, that if I do studies where I interview people, or they fill out questionnaires, and how that relates to their blood pressure in terms of their experiences of racial discrimination, you'd like to think that if there is some real biological process going on here, then if you try to study it in different ways, you'll come to the same answer. It would be very strange if you did studies, for example, where you interviewed people and got certain associations between experiences of discrimination being reported and whether people were at risk of high blood pressure, and you had completely different kind of results happen in a laboratory setting where, for example, if you showed people racist incidents and somehow their blood pressure went down, that would be very strange. So when you do any kind of study, you always want to see what the related evidence might be to see if it's starting to create a consistent picture or not, to give an answer to the question that you have.
Okay. It seems that there is a lot of attention devoted to racism and health right now. I know Unnatural Causes, a lot of people have been viewing that on PBS, and I saw you were on their website sharing your views on the work that you do. Some of the reports that I read that you have done, you talk about how this is not a completely new thing to have a person suggest that they think racism has a adverse impact on the health of non-white people, that there have been non-white doctors who said this years and years ago. Could you kind of talk about some of that history of individuals who've asserted that racism does have an adverse impact on health and how that history has evolved?
There were huge debates, for example, in the U.S. in the 1830s and 1840s about the health status of the black enslaved population, also the black free population, as well as what was then called the quote-unquote native white population, and whether the worst health seen among the black population compared to the white population was a result, and particularly among the enslaved black population, was the result of inherent genetic differences and quote-unquote black inferiority, as it was described at the time, versus white superiority, or whether it was due to the conditions, the very, very different conditions in which people lived. And it's important to note that two of the first credentialed African-American physicians in the U.S. during that time, Dr. James McCune Smith and John S. Rock, both were abolitionists and both not only argued ideologically, but actually had evidence to show that if you made comparisons, for example, of poor blacks and poor whites, you ended up seeing much more similar health status than if you compared them to better off whites for both groups. And that they also argued that the reason for the worse health status had everything to do with issues of being enslaved and being impoverished and living under terrible conditions, terrible material conditions, terrible social conditions, terrible psychological conditions. So these arguments were made, and there were discoveries made, for example, Dr. Rayburn, who was very involved with as a U.S. Army physician with the Freedmen's Service after the Civil War happened, of finding that many times that there had been these assertions of racial, ethnic, particularly black-white differences in health that actually didn't seem to be there when you looked at people who lived under similar conditions as started to occur with some of the conditions in the military. And so you have had discussions that have gone on for centuries in this country about whether the differential health status you see of white and black in particular, but also American Indian, later broadened to include Mexican Americans, Chicanos, Latinos, and then also different Asian American groups, whether those differences are because there's something uniquely different, allegedly innate and biological about these different groups versus the consequences of racism in separating how the conditions in which people live and work and therefore what their health status is. So these are not new debates, and we have had different rounds. More recently, there was a whole wave of research that was done, not surprisingly, in the 1960s in conjunction with the Civil Rights Movement that was looking at, again, explicitly how that's where you have some of the first studies trying to look at, for example, how racial segregation is affecting blood pressure. There were actually studies that were done in the 1950s that looked at racial residential segregation in relation to risk of infant mortality. So there's been a small stream of research. There was work that was done also, for example, in the 1930s, one of the first population-based studies, meaning that it was looking at people who were representative of the communities, not just people who came in, for example, for medical care or brought in to be part of a particular study, that there were surveys that were done in New York City, for example, and looking at the health of poor blacks and poor whites in different areas of New York and finding that they were, again, fairly comparable, especially compared to the better-off whites. And, of course, there is the classic study that W.B. Du Bois did of the Philadelphia Negro in the very early 1900s, which, again, was making the argument very strongly and very clearly that the sources of the worse health of black Americans compared to white Americans was to be found in social and economic conditions, not in their allegedly innate biology. So there's been a long stream of research. It's just that it's not been the mainstream research. And what's happened recently, the mainstream research has been much more invested in the idea that racial ethnic disparities in health are due to differences in genetics. And there's also been a separate side stream that's related that has very much kept alive the idea of racial inferiority, as per the work that's gone on still even now on IQ and all the rest. But the point is that the work has been there. The question is whether it ever gets to become more prominent or not. And what's been very encouraging is that in the past decade, there has been a groundswell of work from many different groups concerned with many different kinds of health outcomes, concerned with many different racial ethnic groups, all doing better and better work documenting what the toll is of racism on health. And that's through many different pathways, whether it's through different kinds of exposures at work, or the kinds of neighborhoods in which people live and what the pollutants are, or interpersonal encounters with racism, or how racial discrimination affects what kinds of jobs people have, and therefore what their pay is and their living standards. The many different pathways, because there's not just one way that racism harms health. There are many different specific pathways, and it matters understanding all of them.
Mm-hmm. I was someone in the chat room. They wanted if you could clarify what you mean when you say interpersonal contact with racism.
So some of the ways that people describe the different kinds of experiences that people can have. Some can be the kind where they are encounters between two people or between different groups of people, face-to-face encounters that cause psychosocial distress and trauma.
Oh, so wait a minute. Can we lower the vocabulary a little bit, please?
It's a direct interaction between people. So this is not about, for example, watching something on TV. It's not about, for example, experiencing unequal pay for equal work, especially when you don't even know that the other people are being paid more than you. This is about when you have a direct encounter with someone or several people where it's a face-to-face encounter and there is something that occurs that ends up translating into some kind of racial injustice. So the interpersonal means that it's actually happening between people who, in effect, are, if not literally, can be looking each other in the eye and having this exchange.
Okay.
And that's different than other kinds of, when you say that, for example, you live in a neighborhood which has higher levels of homes with lead that's not been taken out that's not been abated yet, that's not been removed as a hazard. The lead, the differential distribution of lead, how lead is distributed in old houses, is a consequence of racial residential segregation, but there's not a direct interaction of the person with another person about the lead necessarily.
Right.
There's the you and the lead, and that's not the same as when it's you and the other person right there.
Right. Okay.
And they both matter. It's not one or the other.
Exactly. That was something that really stood out when I was reading your materials that you talked about. It's racism, white supremacy does not just have a adverse impact on the health of non-white people in terms of like having a white person in front of you being mean or calling you names and things of that nature. Exactly what you just talked about in terms of housing, or because of racism you live in a neighborhood that does not have sidewalks or has smaller sidewalks, or you live further away from a hospital, or you live closer to a toxic waste dump, things of that nature where racism is still having a huge impact on your health, even though you might not be in direct contact with a racist white supremacist. I thought it was also very interesting. You talked about how there's a cumulative effect of mistreatment if you are experiencing these types of daily slights on an everyday basis, and living in an area that is maybe not the best for your health, that over time that adds up and has an impact on your health. Could you share a little bit about that with us as well?
There's a lot of work going on in public health and in research more generally now, realizing that to truly understand anybody's health, you need to understand what they've experienced since they were conceived, basically starting in utero, and that the mother's health actually matters enormously for how the fetus develops and how healthy or not the infant is, and if the infant is born prematurely or not, and what that means for someone's health. So there's a lot of work now being done that says that it matters to consider exposures across the life course, from in utero, from when you are in the womb, until the time it is that you actually get sick. Now, clearly, for some kinds of exposures, if there's a toxic spill at work, it doesn't matter who you were before that toxic spill happened. If there's all of a sudden a lot of chlorine there, it's not good for your breathing. So there are things where sometimes your prior history doesn't matter at all, because the kind of insult to your health is so acute and dramatic, it just wipes everything else out, and you can become very, very sick. Or similarly, if you're in an unsafe workplace and there are unsafe guards and you have injury and you end up breaking a limb, again, that's not going to, your prior experiences may not be relevant to the likelihood of your limb getting broken. Anybody's limb would be broken in that situation. So, but the thing is what's happening now is for a lot of the chronic diseases, particularly diseases like heart disease, many different kinds of cancer, diabetes and others, people are looking to the early life origins, but not just the early life origins, but to what your experiences are and your exposures are from when you're born to whenever it is you develop the disease. So that's a model where you can have cumulative exposures to lots of different experiences that can together increase your risk of becoming sick. So it's not seen at all as static or as one time, but instead is lots of things adding up over time. And there's a fair amount of evidence to support this, but the thing is, as you can imagine, actually doing real studies to test that requires following people with good data from when they were conceived to when they develop as an adult and develop disease. And there are very, very few studies that actually have all that data on people. So people try for that long a period of time to follow people is unusual. So there are some follow-up studies which you can get a lot of years of observation, but those are, again, fairly small. And so that's areas of work where people try to look at what adults currently say about what their earlier experiences were and try to create a more full picture that way, where they try to get information on what people's birth certificates are to find out what people weighed when they were born and whether they were premature or not, and things like that.
Wow.
So it's always important to distinguish between what some of the ideas and the hypotheses are, and then how good or not the evidence is to actually support them. Because I think that the history of racism in science shows all too well, people can run with speculative ideas that way outstrip whatever the data are to actually support them.
Right. Again, Dr. Nancy Krieger, Harvard's School of Public Health. I found it very interesting. You talked about a key indicator of human health is looking at the infant mortality rate. I was hoping you could talk about that, and specifically, I think when I was reading your material, you were focusing specifically on black people in the United States. If you could maybe share some of that information with our listeners about infant mortality rate, how that correlates to overall health, and specifically with black people in the United States.
So there are two things to keep in mind when you think about the situation with infant mortality in the United States. The first is things have gotten much better for everyone over the past century, and rates are over 10 times lower what they used to be, even more. So on the one hand, the infant mortality rate has been declining enormously among the black population, also among the white population, also among others. What's happened, that decline as it's gotten to lower levels, at the same time, what's also happened is there's been a persistence of the black-white gap in infant mortality rates, so that you still end up with infant mortality rates being on average about, depends, but on average about 1.5, 2 times higher among black compared to white. And what you also find is that you see this gap in just about every socioeconomic stratum, and by that I mean you see it among people who have less than a high school education, you see it among people who have a high school education but less than 4 years of college, and you also see it among people who have 4 or more years of college education. So the fact that there is a black-white gap that persists, even as rates have improved, things have gotten better, and it's important to keep in mind that things have gotten better, because that's an important reminder that we can make a difference and can actually have an impact on reducing unnecessary suffering. It's not as if the fact that there was a twofold risk now and a twofold risk in the early 20th century means there's been no change, because it's been really important that rates have declined for everybody, but they have declined in a way that hasn't allowed for there to be a closing of the racial ethnic disparities in the infant mortality rates, and that's what's of real concern.
Just for our listeners, I want to clarify that gap in terms of there being a higher infant mortality rate for black people in the United States, a higher infant mortality rate than that of white people. That would be further evidence of racism, white supremacy. Would that be correct?
Well, actually, that's the issue, because the point is that this depends on the framework that you use and the hypotheses that you test. You can't just read directly from the existence of a black-white gap to assume that what is explaining it is racism. I think that's a very important hypothesis and one absolutely worth testing, and I think that it's the likely explanation. But the point is there's also been a ton of people who have looked at those same data and concluded that there's something different about the races biologically, innately. And so I think a really important point to get across is that you need to look at what the theoretical framework is and the kinds of questions people are willing to ask. And for all too long, many scientists were not comfortable asking about, are these differences due to racism, as compared to thinking that they may be due just, quote-unquote, simply to racial ethnic differences in genetic composition, and therefore somehow the likelihood of having different outcomes. So I would never say that it is obvious just from the existence of the disparity that racism is the cause. I think that's the most plausible explanation. But I'm also very aware there are other people who will argue differently looking at those same data. And that's why it's so important to take the next step of actually doing a scientific investigation and testing the hypotheses to show that it is different aspects of racial ethnic inequality that are driving the racial ethnic disparities in health.
Okay. I wanted to clarify for our listeners, I did not say that infant mortality rate difference between black people and white people in this area of the world. obviously means that there is racism, white supremacy. I said the evidence would seem to indicate that would be evidence of racism, white supremacy, and you said that seems likely. Is that correct?
Yes.
Okay, right on. Justice, did you have any questions that you would like to ask Dr. Krieger? Justice, are you with us?
Hello?
Yes, ma'am. We can hear you. Did you have any questions that you would like to ask Dr. Krieger?
Have you learned of any medicine or treatment that harm non-white people?
I don't, no. I don't think that there are medicines that have been uniquely designed just to harm people who are not white. I think that there are many medicines that have dangerous side effects, and that matters for many different kinds of people.
How do white people practice racism and white supremacy?
Again, that's a very large question. There are many different answers to that question. I'm most comfortable in this radio interview responding to questions that have to do with specifically the question of how racism harms health. So, for example, in the case of how racial interactions, if white people treat people of color with disrespect, with abuse, with ways that attack people's sense of dignity and their self, that put people on the defensive, then that can produce stressful situations, and which people respond to both psychologically, and part of the psychological response can lead to a response in the body where they get activated in terms of their stress response, and if that happens many, many, many times, it's thought that can lead to situations that start to damage people's health. That's one way, but also one way that people can respond to difficult situations, and this is not just how people of color respond, it's how anyone responds, and the same is true, by the way, for that stress response. Anyone who is subjected to demeaning and degrading conditions will respond with and find that those are stressful. Is to do something else to try to make it okay. Sometimes that might be having a drink of alcohol or smoking a cigarette, and those can affect your health also. But that's in a different way than the direct responses to being treated badly and having a stress response inside your body. So I think that those are some of the ways in interpersonal reactions that you can watch how a bad interpersonal reaction that's shaped by racial injustice can start to affect somebody's health. But there are many ways that go way beyond what are just the quote-unquote practices of white people when they're engaging with people of color. There's questions about having assumptions that certain jobs are for you and not other people, and through racial discrimination at work, ending up without direct interpersonal interactions, having some people be in worse-paying jobs and others in better-paying jobs, and having a lower standard of living makes it very difficult to be able to live under conditions that are healthy, to live in a neighborhood that is safe, to live in a neighborhood that has a supermarket that sells affordable fruits and vegetables, and all the rest. So there's not going to be one simple answer to your question.
Okay. Probably all for now.
Okie dokie. Again, Dr. Nancy Krieger, Professor, Harvard's School of Public Health. Your report that dealt with racial discrimination and how that might have an impact on low birth weight and preterm deliveries. You talked about individuals who reported incidents of racial discrimination, that there was a correlation with extremely low birth weight. And I really want to emphasize that because that was in the report. I'm quoting directly, extremely low birth weight and preterm delivery. Can you talk about what some of your findings were in this particular study?
That study was led by a colleague of mine, Dr. Sarah Mostello, and it was using data from the CARDIA data set. The CARDIA study is a study that was established in the 1980s to look longitudinally over time. It enrolled a cohort of about 5,000 young black and white men and women from 4 different cities in the United States. They were 18 to 35 years old at the time that it was enrolled, and they've been followed up ever since. And that's what I was saying, that it takes a lot to set up a study like that then tries to follow up people for 10 years, 20 years now for that study. And what happened with that study is that at an early point in that study, because there are repeat interviews, the people who are participants are interviewed again every few years. The investigators in that study were interested in my work on racial discrimination in health, and they added the questions that I've developed as a short instrument, a short questionnaire that can be used effectively in studies that are done when you're asking lots of different questions about lots of different things to people who are in a sample or in a survey. They included those questions, and what she did was then look at people who became pregnant and had a baby, and so that the question about their exposure to racial discrimination occurred before their pregnancy, and then they were able in the follow-up at the subsequent next wave of the interviews to get data on what the birth outcomes were. So that's who the study population was for this study. And what's important about that study is that, first, it showed, as in many other studies, that if you just simply compare the likelihood of having a low birth weight baby or a premature baby among the black compared to the white woman, there was the standard expected twofold elevation in risk. In other words, the babies who were black were 2 times more likely to be low birth weight or premature than the babies who were white. What we also found was that if we took into account many other factors that might, for example, affect the likelihood of being low birth weight, they didn't explain the black-white difference. So if you looked at other things that matter, for example, how much the mother weighs, what her educational level is, whether or not she drank alcohol during the pregnancy, all those kinds of things, that didn't explain the racial ethnic difference, the black-white difference in risk of these outcomes. But what we were able to show is that when you added the exposure information about experiences of racial discrimination, that did make the black and white babies at equal risk of being low birth weight. So what that says as a finding is that if you take into account the differential exposure to racial discrimination, it explains the higher risk that you see in the black compared to white population for being a low birth weight baby. And what we also showed was that the main pathway to this was through premature delivery. And there is work that's being done by other people, I'm not involved in these investigations, that's trying to look more carefully at the question of how adverse conditions, psychologically adverse conditions during pregnancy could perhaps, because of stressful responses, lead to preterm delivery. So I think a really important point to make is that it's not that there's a unique response among black people to stress. It's that they are uniquely exposed to certain kinds of stress, which, if anyone were exposed to that kind of stress, would have a worse health outcome. And that's a very important distinction because it makes it very clear that the problem lies in the kinds of experiences people have and not in some kind of special, unique biology of one group compared to another.
Right. I agree wholeheartedly. I did want to point out from that same study, was reported that women reporting high levels of racial discrimination were almost 5 times more likely than women reporting no racial discrimination to deliver a low birth weight child. I just found that stunning. I also wanted to look, as you, like I said, just have done an incredible amount of research around this, or have been involved with a lot of research around this. You also participated in a report that investigated breast cancer. This report is breast cancer a disease of affluence, poverty, or, I'm not reading my writing correctly, I'm pretty certain you know which report I'm referencing.
Yes.
But you talked about in that report how breast cancer is, I guess, perceived in the media or in mainstream as an affluent disease. I think a lot of people would perceive that to mean white women who have, a fair amount of money. Where you talked about in this report that when you actually look at the data, black females in the United States have one of the highest rates of mortality from breast cancer in the world.
So what's important to say here is that when you're thinking about what people die of, you actually have to ask two questions before you get to the point where somebody actually dies. First, you have to ask, did they get the disease or not? And second, you have to ask, given that they got the disease, how good or not was their survival? So you can have, in the case of breast cancer, what has happened in this country is that white affluent women actually still are at the highest risk of getting breast cancer. And this has to do predominantly with patterns of having children, exposure to hormone therapy, lots of other things I can talk about. But the point is that once you're diagnosed with breast cancer, then what happens in this country is that those who are best off economically are best able to get the best treatment and are the least likely to die of the disease. So what happens with regard to mortality is that you have black women on average being at lower risk of getting breast cancer, but once they get it, at higher risk of dying from it. And those two things put together result in black women having a higher mortality rate from the disease, even though they're less likely to get the disease. So I think what this example points out that's very important is that there's not one simple way that you can expect in any given disease that the racial ethnic patterns of inequality will play out similarly. Because here for breast cancer, which is something I've been looking at for a long time now as a disease, you actually have a lower risk on average among black compared to white women for being diagnosed with breast cancer, but much worse survival for the black women once they are diagnosed, leading to their higher mortality rates compared to white women. And all three of those things are true at the same time. And so what's very important is that in terms of, and I think that some of the breast cancer organizations in the past few years have begun to address more clearly that breast cancer is not just a disease of white affluent women, and that the mortality rates are much worse among women of color, and that this requires attention. And so I think that what's been happening, which is very important, is that there's growing awareness that it really matters to understand how common breast cancer is as a cancer for all groups of women, and that some have much worse mortality outcomes than others do, and that this needs to be dealt with.
Wow, I want to definitely address. You have so many studies. There's another one I definitely want to get to that deals with high blood pressure. But before I move to that, I just wanted to sticking with black females in particular. When Dorothy Roberts was on the program, she said that one of the common myths, I guess, that you hear a lot is these pregnant black females on welfare and da-da-da-da-da. And she said that, when you begin to look at the evidence, black females in this area of the world, their infertility rate is rising. I just wanted, if you could speak to that, if you know whether or not that is accurate, and if you could speak to that.
I actually don't know the information on that. I mean, I am aware of differences in infertility rates, partly due to differences in pelvic inflammatory disease, but I don't have expertise in that area to say anything.
Okay, no problem. the high blood pressure study. This is racial discrimination and blood pressure. I found it fascinating for a myriad of reasons. At the beginning of the report, there are listed different factors that might contribute as to why there is such a disparity between high blood pressure for black people and white people in this area of the world. And three factors that are listed. One is suppressed anger. One is internalized racial oppression. And the other is John Henryism. I was hoping you could explain those three factors for our listeners.
The first two are related to the question, as I mentioned before, about how people respond to situations that are psychologically stressful, and that our bodies have what's usually referred to as a flight or fright mechanism, that when we are scared, when we are threatened, we respond in ways that enable us to run, and that pump up our blood pressure, pump us up so that we can basically flee or in some way confront the aggressor. And the problem is that the hypothesis, and again I stress that this is a hypothesis and there's a lot of active work trying to show whether or not this is correct, is that if that happens to somebody repeatedly, you start to end up with the systems that are involved in the body with those kinds of responses getting dysregulated, getting off, so that you're actually constantly being overstimulated and constantly having your blood pressure high at an elevated level, as opposed to just in those circumstances where you're responding to a direct threat. So the issue with both the internalized anger and with the rumination, this is constantly thinking over what's happened to you, is that, and the negative encounters are chronic and persistent, and they add up over time, and they cause damage to health in that way. The John Henryism is related to that. John Henryism is a hypothesis that was developed by my colleague, Dr. Sherman James, who's now at Duke University. And that was about the idea that you have John Henry, as you well know, was the railroad worker, the African-American who competed against the machine and burst his heart trying to drive the iron stakes faster than the machine. This is back in the 1830s, I believe, or 40s. And the idea there is that you're trying so hard to do better despite all the obstacles that are faced in front of you. And that those who were basically saying that they were doing fine confronting these obstacles may, in fact, those obstacles really took a toll on their health. So that's not quite the same as the stress response, which is what the others two deal with, because that deals with other kinds of wear and tear on the body that come with dealing constantly with adversity, but that would also involve the different kinds of jobs that people work at, not just their, again, interpersonal interactions that are threatening. So those are some of the different kinds of pathways that have been hypothesized. But as I say, that's one part of the picture, because other things raise blood pressure too. For example, exposure to lead, and there have been black-white differences in lead exposure for some time. That may not be as huge a contributing factor, but it's just important to remember that there are other things that can raise blood pressure as well. Also, for example, being of a larger body size, your heart has to pump that much harder, and you end up with higher blood pressure. And reasons for differences in the body size and obesity are very complex and debated right now, and there's lots of discussions about how racism plays a role in that. But you could have somebody who had a very large body size and yet this is hypothetically possible, not have adverse interpersonal experiences, and just being of a larger body size would put you at risk. Also, people who are born premature, so before they've even had a chance to experience life outside of the womb, can come out with smaller kidneys that are less able to do what they need to do to help in keeping blood pressure at the normal level. And that can put you at risk for higher blood pressure, regardless of any subsequent encounters that you have with anybody. So I think it's really important when evaluating some of the different hypotheses again, about how racism can harm and lead to risk of elevated blood pressure, that absolutely the interpersonal interactions and the obstacles that people face as adults and also as young people are really important, but some of this can even get started by having simply been born premature, and that's because of the racism that's experienced by the mother. And so I think it's just really important to keep this much longer life course perspective in mind, and also these many different pathways, so that you understand that in any given study, when you test one of these ideas, you're doing your best to test that idea while mindful that there are these other things that are also going on.
Privileged to have Dr. Nancy Krieger on the program with us today. I had not heard of your colleague's theory, John Henryism, in terms of non-white people just working so hard to overcome the obstacles of racism, white supremacy, and that ending up having a negative impact on their health. I had not heard that before. Actually, I really hadn't been informed about the other theory of suppressed anger and how much of an impact that has. When I continued to read the report on racial discrimination and blood pressure, it noted that for the women that you were looking at in this study, that it was much higher incidence of high blood pressure were much higher or significantly higher for women who reported experiencing no racial discrimination. And I thought that was fascinating because it seemed to indicate that if you are experiencing racism, but you're not talking about it, you're not reporting it, that has an adverse impact on your health. And you talked about that, or the report deals with that a lot. Could you share that with our listeners? Because I think that's critical for non-white people.
So that was a very early study that I did, which raised this very interesting suggestive finding, and that was a very small study. It was one of my first looking at the question of racial discrimination and blood pressure. And it was what made me aware as well, as others have been, that what people self-report is exactly that, what they're willing and able to self-report. And there's work that has been done that shows in the world of social psychology what's called the person-group discrimination discrepancy, which is a long title. But what it's about is that people, on average, report less discrimination for themselves than for their group overall. And on the one hand, you might think, well, that makes total sense, because I can imagine many different people, not just me, who have experienced discrimination, and I've only experienced a very small part of it. The problem is that when you survey a whole group of people, and everyone is saying that, everyone is saying that everybody else is experiencing more discrimination except for them, that's just not possible, because somebody has to be experiencing that discrimination. So there's a sense that people do self-report less discrimination than they may actually be either able to recognize or willing to name, because it may be uncomfortable to name it in that particular situation. It depends how the interview is done. It depends whether it's a face-to-face interview. It depends whether you're filling out a piece of paper and you don't actually have to see anybody. There's lots of different reasons that you might not get a full accounting of what people's experiences have been simply by asking people questions. I think that this is where, for me, and the kind of work that I do, it's very important to see not only what are the stories that people themselves tell when you ask questions, but also what stories their bodies tell. And we can quickly go to other examples where you can think about bodies telling stories that people could not. That was very important, for example, in finally acknowledging the reality of child abuse, where children were not able to name their experiences, but their bodies absolutely showed that they were being abused, whether physically or sexually. And so it's really important to think about where you expect people's responses, their verbal responses to questions, to be fully informative versus perhaps only be telling part of the story. And so I have been in different ways since following up on the idea, because another study that was then done, I did later with a Cardia study, found that, for example, whereas among the African American participants who were college educated, you saw that the more discrimination they reported, the higher their blood pressure. Whereas among the working class African Americans, both men and women, you saw something that was somewhat similar to what I saw in that first study, which was that among those who reported no discrimination, their blood pressure was a bit higher than those who reported some discrimination. But it was still highest among those who reported lots of discrimination. So if you think about it, that makes a little J in terms of the curve. So it's a little higher among those who report no discrimination compared to those who report some or a moderate amount of discrimination, which might be considered, the norm, which is obviously a terrible thing, versus those who report lots of discrimination. And that's further suggestive evidence that something is going on among people who do not have power that affects their ability to name racial discrimination as something that they've experienced, even as their body is suggestive that something is going on. And what's interesting now is that this kind of finding has been replicated in several other studies. So it's not just a one-time or two-time observation, but that it's, again, particularly among those who have fewer resources that you see this kind of relationship. So this, again, makes it very clear that it's not something simply about being black or not. It's also about, do you have resources or not if you are black, and how that shapes what your risk is and what your likelihood is of reporting racial discrimination, as well as what its association is with the health outcome, in this case, blood pressure. And it raises ideas that then it's important that social psychologists and others who work on how people do or do not report their perceive and report their experiences of discrimination. There's a lot of work to figure out on that. But I think a very important point in this finding is that it also speaks to why I find some of the language about quote-unquote perceived discrimination to be problematic. Because perceived discrimination implies that everything is conscious. And I think that the findings that we're beginning to get in epidemiology right now are suggesting that there can be experiences of discrimination that the body is recognizing, whether or not people are willing to consciously verbalize them to you as an experience that they've had. And there are ways to test that we're working on now in current research that's underway.
Wow. That has been a recurrent theme on this program and my own studies of racism, white supremacy, that frequently non-white people are being mistreated and experiencing racism, white supremacy, but sometimes they're not aware of it. And your research would seem to indicate that even if you're not conscious of the fact that you're being mistreated and experiencing racial discrimination, your body can still register that, and it still can have an adverse impact on your body. Is that correct? Am I understanding what you're saying correctly?
That's the hypothesis, and I think it's going to take a lot more hard work to figure out whether that's true or not, but I think that it's a plausible hypothesis.
Wow. And I didn't want to gloss over, I think that was very important as well, for individuals who are experiencing racism. This particular study dealt with black people experiencing racism and either not having the means to deal with it, to address it, or just choosing not to address it. That also, the evidence would suggest that also has an adverse impact on your health. Is that correct?
Yes, I think that in this country, it's not possible to understand health if you're not simultaneously dealing with issues of both racism and class and also gender. And gender matters here because there are different ways that men and women express themselves and who's more willing to talk. And there's research, for example, that suggests that black men are much less likely to talk about what their experiences are than black women. So there's a gender part in there, and there's a lot of work on gender and racism together and how they work, and also how class and racism work. And it's important to put all three together because that's what you do every day in your body. That's what everyone does. We don't walk around, one day being black, another day being a woman, another day being working class. Those things, they go together or they might not, and you might be black professional and male. But those different things are then the combinations of what people experience, and it's really important to address that in the work and not to assume that there is just one unique thing called being black that has a certain experience, or one unique thing being female that has a certain experience, because you have to think about how these things actually interact in the social interactions that we have, but also combine within our very bodies.
Wow. Before I switch to a different topic, I did want to get also this study. It was reported that the racial reports of racial discrimination and how the individuals responded to that racial discrimination, the impact that that had on blood pressure was on par with other risk factors, smoking, alcohol, being overweight. Is that correct?
Yes, that's what we observed in that study.
Okay.
And so what that suggests is that it merits attention as a possible risk factor to the same extent that these other exposures do.
Wow. I want to echo that for our listeners. Experiencing racism merits the same attention, these studies would suggest, as smoking, being overweight, drinking, consuming alcohol in terms of blood pressure. I just, incredibly important. Justice, did you have some questions that you wanted to ask Dr. Krieger?
Yes.
Okay.
Why do some white people who practice racism and white supremacy hurt the health of non-white people, even though when we are already in a system of white supremacy?
You'll need to repeat that question. I think it's very similar to the one you asked me before, so could you please say it again?
Why do some white people who practice racism and white supremacy hurt the health of non-white people, even though when we are already in a system of racism and white supremacy?
If I understand your question correctly, you're asking why it is that there are white people who, above and beyond the fact of being in a system of white supremacy, hurt the health of people who are not white. Is that what you were asking? I have to say that I have not done empirical research that directly addresses that question. So I have not looked at the question of, there's a lot of research that's on people who are prejudiced and people who harbor feelings of racial bigotry and people who are actively racist. And that's very important work. That's not the work that I've chosen to do, because for a long time in psychology, that's where a lot of the emphasis was. It was on the people who were themselves the ones discriminating and trying to understand their attitudes. And what I found that was very important, and the reason why I do the work that I do, is that there was surprisingly very little work done on how being a target of racial discrimination affected people. So although I think it's very important that their work be done by psychologists and others to understand some of the thinking and feeling that goes with being someone who would actively seek to hurt another person because of their racism, that's not an area that I've chosen to do work in. I've chosen to do work in trying to understand what the health harms are. And the reason for that is not only, as I said, the lack of research that had been on that from the point of view of the psychological emphasis being on people who discriminated and not so much on who was discriminated against, but also because there was such a long legacy of scientific racism that was attributing the worse health of people of color to their innate inferiority in one form or another, as opposed to what the experiences are with injustice. So although I think your question is important, it's not something I can address from my research, and I've just explained why.
Okay, and what do you mean by prejudice?
Different people mean different things by that term. I was using that specifically in the sense that's been used in a lot of the work that's been done in psychology, where prejudice, the idea of prejudice is prejudged, that you decide that you already know something about someone based on a particular characteristic, and that you actually have already decided that you think that they are a lesser human being for that reason. So that you can be prejudiced on grounds of race, you can be prejudiced on grounds of class, you can be prejudiced on grounds of sexuality, you can be prejudiced on grounds of many different things. But prejudice usually refers to people's attitudes. And you were asking about your question, you were asking about people who would choose to act to harm other people, which does involve attitudes. The important thing about racial discrimination and racism more broadly is that it can also involve, as a system, as you keep bringing up in your questions as well, situations which don't involve one person directly seeking to harm another person who is right before him or her. It can be institutional discrimination, where rules are set up that end up harming certain groups of people against others. And that matters enormously in terms of how racial discrimination can work. That's why there's so much work that's been done in institutional discrimination, which is seen as different from just prejudice.
Okay.
I definitely want to give opportunity for folks to call in with questions. I wanted to look at one more of the studies that you've been involved with, Dr. Krieger. But if you would like to call in with a question, 347-215-6071. It's the number. You can give us a jingle. The report, it's Does Racism Harm Health? Did Child Abuse Exist Before 1962? It's a pretty long title. Those of you who are looking, I think that's enough. If you Google that, it'll pop up. Dr. Nancy Krieger, if you put her name with it, I'm sure you'll be able to find it. But you talked about, you made two important distinctions. One was a biological expression of racism, and then the next one was a racialized expression of biology. Could you explain those for our listeners, please?
Sure. So the thing is that you want to say there are differences in health status between these two groups, black and white. This is the example that we're using. Why do those differences exist? And what we've been talking about thus far is that some of the differences that exist between groups can arise because of what the adverse relationships are between the groups, so that the racism that people of color experience, or in this case that blacks experience, leads to their poorer health status. So what that means is that the poor health status, whether that's measured as risk of diabetes or risk of blood pressure, higher blood pressure, or whatever the health outcome is that's chosen, that becomes, you measure it biologically in the body, you measure the existence of that health condition. But just because you've measured it in somebody's body doesn't mean that it's somehow innate to that body, that it's genetically predetermined that that person gets that disease. That instead what you're measuring is what I'm calling the biological expression of racism, that the way in which racism affects the biology of somebody that you then measure, so they end up with higher blood pressure. It's not unique, it's not built into them that they have that higher blood pressure. It's a consequence of how their biology has been affected by racism. So that would be a way that you would talk about a biological expression of racism, that you could actually measure something biologically in somebody's body, such as higher blood pressure, for example, but you don't make the next step of assume that somehow that's because of that person's body and not because of the context in which that person is living in that body. The other side of what I was calling racialized expressions of biology is that people have taken certain aspects of people's biology that, again, is noticeably different. One of the important points about racial groups is that they are typically distinguished in part based on physical characteristics involving, for example, skin color, sometimes involving hair, sometimes involving different aspects of facial features, although no one group can ever be uniquely distinguished from another on the basis of any one of these different traits. And people will say, well, because people have different skin color, then there are obviously there are real biological differences between them, and that's what matters, and that the skin color is indicative of that. But the point is that skin color has become racialized. There are some diseases that are related to actually what the color of your skin is. One, for example, is a kind of skin cancer known as melanoma, where people who have very little melanin in their skin, that is much fairer skinned people, are at much higher risk of getting the disease than people who have darker skin. But that is a really important point, which is that you can have differences in that one particular biological characteristic, the color of your skin, but that doesn't necessarily say anything else about the rest of your biology. So you can be someone who's at, for example, very low risk of getting melanoma, but be at very high risk of getting this disease and maybe not at high risk of getting another disease at all. And you could be a white person of very high risk of getting melanoma, but at very low risk of getting diabetes and very low risk of getting heart disease, or maybe you're at very high risk of getting breast cancer. So just knowing about what somebody's skin color is not actually going to be biologically predictive of diseases that don't directly relate to what your skin color is, like melanoma. So when skin color gets turned into a racial marker, you have racialized the biology. You're making something that is very specific, skin color, all of a sudden stand in for many, many other possible biological characteristics, and that's a false assumption. That's wrong. And there has been work that has been done to show that, for example, both in Brazil, also studies in the United States, other places as well, that when you look at somebody and you simply measure what their skin color is, it's consistent with having all different kinds of genetic makeup. You can't read from somebody's skin color to what their genetics are, what their own genome is. When people do that, they're wrong, and they've racialized a biological trait. And that's what I mean about racialized expressions of biology. So that's where racial ideology ends up affecting and distorting how people understand biology.
Outstanding. I want to get a caller or two, folks who've called in. Your area code is showing up as 111, so not sure, but 111, if you have a hand up, if you have a question for Dr. Krieger, go right ahead.
Yeah, that could be me. I'm calling from Skype.
We can hear you, sir.
Oh, okay. Well, one of my questions is, and I mean, I'm one who's experienced racial discrimination to a degree that I never thought I would experience in my own community. And, there comes a point in your life where, well, even through the process, I mean, you continually ask yourself, why does this happen? Like, what is the root cause of discrimination? I mean, is there any study that has taken a good hard look at, is there something, within a particular culture that festers this or fosters this kind of behavior, or,
I mean, there is a lot of work that tries to look at why do we have the adverse antagonistic race relations that we do in this country. And you want both simultaneously to understand what's going on in people's heads right now, but also what historically has gone on that set this up. And there are certain things about our society having been founded in part on expropriation of land from American Indians, and also with slavery, and that slavery being specifically directed to involve people of taken from Africa and therefore of African descent, and having a racialized system set up from the get that got codified into law that changes the ways people think and what their expectations are about other people's humanity. That's been set up, that we have a very particular historical situation in this country that can't ever be overlooked in trying to even understand the current legacies that we have based on what the history has been. There is work that's done in psychology more broadly about how there are in-group and out-group mentalities, that people tend to be very tend to be very suspicious of people who are not quote-unquote part of their group. But who gets defined as part of your group or not is not just a psychological process. It's a social and historical process. So the fact is that you can have this replicated in different societies that have different histories as well. You have issues now in many European countries where they have immigrants that have come from countries that they previously colonized, and there's racism that's involved there as well. Usually you have racism occur when there has been some version of taking over of people's land, property, or labor on the basis of what's considered to be a racial division, and having that play out over time.
We had Another person called in, 909.
Hello?
Got you. Yes, sir, 909. Did you have a question for Dr. Krieger?
Yes. Dr. Krieger, are you familiar with Dr. Bruce Lipton?
I don't believe so. If you say more, please.
He wrote a book called Biology of Belief.
Okay, that book I don't know.
Okay, that's an important book. It talks about how your beliefs affect your biology. And basically, I think that, well, I don't think, but I just see after reading that work is that really, to me, racism, white supremacy is kind of like it's a perfect opportunity to strengthen oneself. But if you're thinking about it in the ways that you laid out, where it affects you, and you're not really cognizant of it, and it affects you by you start drinking and smoking, and you don't really know why, but it's because of the effects of the discrimination that you're being subjected to. But for me, it's a good thing, actually. I mean, I don't know how to. If you're under attack in certain areas, then you can strengthen those areas. But the book goes into it saying that when you have my belief is that when if I'm being discriminated against or if I'm under attack, then what I'm saying, it just strengthen that area in my life and understand it more, and it empowers me. So
I think what you're raising is a very important point, and this is a part of my research that has also been active, which is how do people respond to racial discrimination? How do people address it, not just simply cope, but actually address it? And one of the questions that I ask is about, do people respond by keeping it to themselves or talking to others, by taking action, or by just accepting it as a fact of life? And showing that, at least as far as the blood pressure is concerned, people who actually talk about it and take action tend to do better in terms of their blood pressure. So there's actually a lot of very good and important work that's being done on how people can be resilient and how people can come up with ways like what you're describing to actually consciously acknowledge what the situation is and also seek to both better and protect themselves at the same time. And that's really important areas of work, because the idea is not that people are just simply victims, but people are actively active. And clearly, if people were only victims, we never would have had the civil rights movement in this country, among other things. So I think what you're raising is a very important point, and that's another part where there is active work done on resilience. The only thing I want to say is that just as people may say that having a certain disease made them suddenly appreciate their life more, it doesn't mean having the disease or experiencing racism is a good thing. It does matter that you work with the knowledge of what your situation is to make it as good as you can and not to let it get you down further.
I had a question. It's related to the report that you did about does racism harm health? And you talked in the conclusion in that report, it talks about the importance of explicitly acknowledging the impact that racism has on the health of non-white people in the same way that you would explicitly acknowledge tobacco has harmful health side effects, drinking alcohol, harmful side effects, that you feel that is an important means of correcting this problem, that it needs to be explicit and more research needs to be done as to how that happens. Could you share some of that with our listeners?
I think that that's still where the research stands, that this question is still out there and that there are colleagues who are engaged in work looking at the different ways that people do respond to both knowledge of institutional discrimination as well as to interpersonal acts of discrimination. And again, I think it's important to keep in mind that both matter in terms of what people's health is. So I would say that that's an area of active response. That tends to get more to people that are doing health interventions. And I think this is where it's important to understand that people that do research on health and racism in health can come at it from many different kinds of approaches and with different questions in mind. So my questions are the kind of what makes people sick. Other people may do research that asks what keeps people well and what are interventions to help people stay well. And that's also very important kinds of research, and I think that it just becomes important to recognize that one can't take on every question, and you end up with expertise more in some areas than in others. So what I do in my research is include questions about what are the different ways that people respond, and not only respond individually but collectively. But that's different from people that are actually designing interventions that test different ideas about how people respond and work with them to come up with better responses without in any way doing victim blaming.
I did want to be clear. You are saying that it is important to explicitly acknowledge and confront racism is a problem that does have an impact on health, that is important, correct?
What I think the work shows is you do that in ways that make sense for the situation. Because, for example, it may make sense in some situations to have a direct encounter, and in others it may not, because you're going to lose your job, and that's not a good thing either. And that you need to figure out what is that what's not good is to just have the same response emotionally, regardless of context. Have a context-specific response. I think what the research is starting to show, but what I would say is that, so when you say explicitly acknowledge and deal with it, it's a question of where, when, and with whom. It may be one thing to confront something directly in the moment that it's happening. It may be something to talk about it later with friends and with family, or with somebody who otherwise is able to offer counsel to you. So there's many different possibilities there. I have not done the work on that asks which of these kinds of ways of dealing is best. That's what I'm saying, that other colleagues do that kind of work, and I think it's a very important question to ask.
Right. Forgive me for not clarifying in my question. I didn't mean the victims of racism. It's important that they explicitly acknowledge. I meant in terms of healthcare practitioners needing to acknowledge, this is kind of a problem. Racism is a problem. We need to be focusing on this and looking at this in the same way that people acknowledge that drinking alcohol is a problem. Smoking is a problem.
That's actually, I think, very important in what you're bringing up around healthcare professionals, is because the difference is that the alcohol is happening usually outside, or the tobacco, of the physician or healthcare provider's office. But you can also have inequities in medical care due to racism. So there's a whole other very active part of research, which again is not what I look at, but other colleagues do, which is how do interactions between people and their healthcare providers matter in terms of racial discrimination. And so what's happening right now is that there is work being done in a variety of different hospitals to try to actually look at what the awareness is among their own staff about issues of racial discrimination and treatment of patients. And that's something that's a different question than you would say be aware of how does alcohol matter, because they're not typically administering alcohol to their patients.
Right.
Anyway.
We hope not.
So I think that it's important to say that when it comes to the question of healthcare providers, which is a different question than healthcare researchers, there are researchers who are also healthcare providers, but I, for example, am not a healthcare provider. I do health research. That it becomes important to say that when we're trying to understand what's affecting the health of people, we have to take into account the ways in which racism can harm health. And that can include, it's not restricted to, but certainly can include what happens with regard to patterns of treatment. And for example, to give one where, again, it might not be even the treatment within the medical institution. There was a study that was done in Harlem, for example, that showed that many of the pharmacies were not stocking some of the kinds of pain-killing drugs that were needed by patients because of the fears based on racism that they would be abused. So the physicians were prescribing the right kinds of medicines, but people were still unable to get them. So that's different. So that's why I'm saying you can't always go to just what the encounter is, because in fact the physician did give the correct prescription. But then another aspect of institutional racism kicked in that made it difficult for the patients to get their prescriptions filled.
Wow. We had a caller at 720. 720, are you there with a question for Dr. Krieger?
Hotep victims,
Greetings, sir. How are you doing?
Intensely victimized.
Right on.
Wanted to say I hope Justice is feeling better today.
Hello?
Hello, Justice. Are you feeling better today?
Yes, I am.
Oh, good. Good. I have a question. I didn't get a chance to hear all of the show, so I'm not sure. Is it Dr. Krieger?
Yes.
What exactly do you research?
I do work on many ways that social inequality harms people's health, and that includes racism and health.
I'm sorry, I didn't hear everything you said.
I do research on the many different ways that social inequality can harm people's health, and one aspect of that is research on how racism harms people's health.
Oh, okay. Earlier, I think I heard you say that surprisingly little research has been done on people who are targets of racism.
In terms of their health status, how that's begun to change in the past 10 years. But when I started doing work on how does racism affect people's bodily health, there were virtually no studies that looked directly at that question. There have been studies in the psychological literature that have looked at how experiences of racism have caused psychological distress and may perhaps be related to some forms of mental illness. But there was very little research that looked at things like how is racism related to risk of many of the physical diseases that people have.
And when did you start doing research?
In the late 1980s.
I had in terms of racism affecting health, and I think you had mentioned something about melanin, and I wanted to ask a question. There's a Dr. Africa who says that the basis for all science is melanin. He says, for example, biology is the study of how melanin within cells directs energy. The melanin nucleus is the brain and control center for all life activities in cells. And chemistry is the study of the interaction of melanin with melanin. The other goes on to say, scientifically speaking, if Africans flushed all the Caucasian science books down the toilet, it would be the worst thing to happen to the sewer and the best thing to happen for the African science students. Can you make any comments about what you know about how much melanin affects science and the study of chemistry?
I think that there is a very long history of scientific racism, as I've mentioned before, that affects how science has been done, what kinds of thinking people have had about why is health of some groups better or worse than that of others, about whether people are intrinsically different or not based on what is alleged to be race. So I think that there's a lot of ways in which scientific racism has harmed the production of scientific knowledge. I would disagree with the assertion that melanin is the basis for all action in the cell, and I think that that's a question that is not one that we can resolve here in this radio show.
Very interesting. I did want to check. Justice, did you have any questions that you wanted to ask?
Hello?
Yes, ma'am. Did you have any questions that you wanted to ask?
What do you mean by inequality?
When people talk about social inequalities, they are talking about systematic, unfair differences between groups in society. So social inequality refers to different kinds of discrimination. For example, it is an aspect of social inequality when one group is denied jobs that the other group can get, and then they end up with not only different kinds of work, but also different kinds of pay, and are able to live in different kinds of areas. That translates into housing inequalities. So the inequalities are not just simply differences, but they're unfair and they're unjust. And one group is benefiting from the other group not having access to those resources or to that form of power. For example, when there was inequality in voting, whites could vote and blacks could not. That was what Jim Crow was about. That's what legalized segregation was about. And the people that voted would then vote the budgets and would determine where money was spent in states. And you would have enormous differences in spending, for example, in the Jim Crow states, in education for white students compared to black students. So you ended up with many different kinds of inequalities in income, in education, and in resources. So the idea, again, behind inequality, the way that I'm using it, is that it's about something that is unfair and unjust as a relationship between the groups at issue, and one is benefiting from the other being deprived.
And what do you mean by discrimination?
Discrimination is one form of inequality, but not the only form, where one group actively is able to discriminate either legally, as I said before with the example of when it was Jim Crow laws existed and blacks were not allowed to vote or not allowed to be in certain places physically or not allowed to have certain kinds of jobs. So to discriminate means to distinguish between groups, and to discriminate in this sense of racial inequality is to discriminate adversely, to discriminate with harm. There is also work that's done that talks about what could be called positive discrimination, which people find confusing and tend instead to talk about affirmative action instead, where again consideration is being given to a group, but that's because they have historically in the past or in the present experienced adverse discrimination. So to discriminate is to, in the sense of racial discrimination or gender discrimination or discrimination based on sexuality or whatever it may be, is the idea that one group is denying another of equal opportunities and equal resources on the grounds of whatever the criterion is, in this case, race.
What are the best things non-white people can do to stay healthy in the system of racism and white supremacy?
There are things people can do as individuals and things people can do as members of their community and their broader society, and they all matter. So trying to ask it as a question of what can an individual do, on the one hand, people want to be able to live the healthiest life they can, and that does mean things like working in jobs that are safe, living in neighborhoods that are safe, getting good diets that are filled with fruits and vegetables, and many other things, but this is not always affordable or an option, and you can't, and to understand that people need to make changes within constraints means that really it's not just what people should do, it's also what public health should do, what public health agencies should do, and what needs to be changed through legislation, so that, for example, there's work being done right now in Philadelphia to actually bring supermarkets back into the city, which have been lacking supermarkets, so that you could tell people they should go buy their fruits and vegetables, but there was no place to go buy them. So instead of asking what an individual should do, on the one hand, yes, go buy fruits and vegetables. On the other hand, it was also about people getting together and organizing and working to be able to bring back supermarkets into the city so that there actually could be a public option for actually beginning to get a healthier diet. And that's the direction in which public health needs to go. It's not simply about what individuals can do, because everyone recognizes that individuals can only do what they can do in their context, and what needs to be changed is the context. Even as individuals do need to do the best they can in whatever their situation is.
Okay, that'll be all for now.
Okay. some of the folks in the chat room, they just want to be clear about the term racial discrimination. I don't use that term myself. Would it be correct to say racial discrimination is mistreatment on the basis of color?
Yes, that's one part of it.
Okay. Is there another part?
Well, again, the ways that that broadly plays out, but it's the terminology, as long as it's clear that there's interpersonal, there's institutional, etc., there's different forms of it. There's not just one part of it. So the mistreatment can be, sometimes people refer to mistreatment as involving what is the interpersonal interactions, and the institutional does not necessarily involve interpersonal interaction. Oh,
okay. But even the institutional would still be mistreatment on the basis of color, correct?
It's unjustness. Yeah, it's unjust treatment. Correct.
Okay. Just wanted to clear that up for the folks in the chat room. Everybody is good. I wanted to ask, the system of white supremacy, we've had two guests on the program who have talked about racism and health, and they have said they feel the evidence strongly suggests that the system of white supremacy is designed to create adverse health for non-white people. Do you think the evidence would suggest that that is accurate?
I think that an absolute consequence of systems of oppression like white supremacy is adverse health of the people who are being oppressed.
Can you say that one? I didn't hear the first part. Can you say that one more time, please?
I think that a consequence of systems of oppression like white supremacy are that the health of people who are oppressed will be harmed.
Okay. Do you think the evidence would suggest that the system of white supremacy is designed to bring about those adverse consequences?
I don't know that the intent is to harm health of people. I think that is a consequence. I don't know that there is an actual... When you say a question of design, it suggests that there's somebody who's sitting in the back room planning all of this out, and I think that the historical evidence is much more complicated than that. But I think that it is fair to say that without necessarily there being conscious intent of deliberately harming people's health, that is a consequence of systems of oppression.
Again, I don't even think they would be on the campus of Harvard, but I do think there are a lot of examples where white people practicing racism, white supremacy, have intentionally harmed non-white people, harmed intentionally the health of non-white people.
Absolutely, in terms of specific acts of violence, and in terms of indifference to people suffering, and in terms of not caring about paying a living wage, and many of these things. But I'm just saying that. So, I think that there is absolutely a issue of malevolence, but I think there also is a routine functioning of systems of oppression that, by definition, end up harming the well-being of those who are oppressed. And that's not always with conscious intent in every single way that it plays out. For example, it's not that lead was not put into the paint in order to harm people, but who ended up, once it was understood that there was harm due to lead in paint, who ended up living in areas where it was hard to get the lead out of the paint. But it's not that the lead was put in the paint in order to harm people.
I'm certain there's probably a difference in terms of why I strongly suspect that it is conscious. I know just in studies that have shown that in terms of hospitals closing, if you have a lot of black people in that area, very likely that the hospitals will be closing there. Also very likely that you will have a toxic dump closer to your area. That I would tend to think this could be a conscious act, but even moving the consciousness aside, you do think it is correct to say that the system of white supremacy does have an adverse impact on the health of non-white people?
Yes.
Okay. Groovy. We had a couple more folks call in before we wrap things up. 619, are you there with a question for Dr. Krieger?
Yes, I do have a question. Who can eliminate the system of white supremacy faster, white people or black people? And its effect on non-white people's health?
I think that the evidence in this country shows that some of the best reductions in the magnitude of black-white differences in health and in health inequities occurred during the period. I mean, I've just done research published on this, and other people are looking at this now. For certain diseases in the period right after and around the civil rights movement, there was a lot of unmet need that got met as hospitals were desegregated, and people could suddenly get health care they could not have gotten before. But there are also improvements in living conditions, and that I think that the basic lessons that stand from public health is that social movements for justice have had the best effect on reducing unjust suffering, including health inequities. And that's true not only in the United States, but in many other countries as well. So in that sense, answering your question is that what does it take for there to be social movements that are dedicated to improving conditions and reducing inequities? And I think that there are many people who are actively engaged in different parts of that, and that it's that kind of active engagement that's changing the social context that makes the biggest difference. How those movements play out over time, who is involved in them, I think that the ones in this country, at least, that have been very important have been varied in their composition. But certainly it's not a matter of just individuals changing things. It's a matter of there being social change, and that requires people working together to a common goal of health equity.
Okay, there was a couple other folks that called in. 111. I don't know. And now disappeared. Okay. Switchboard is acting a little nutty. Several 111s. Other 111. You have your hand up. Do you have a question, sir? I believe.
Yes, I do. Do you believe it's possible to have this effect that you're discussing between white and black populations occurring within different white cultures? And the reason I'm asking this, I live in Canada, and I live in the province of Manitoba, where the southern part of the province is predominantly Mennonite. I'm not Mennonite. I'm a humanist, and it's predominantly Mennonite, and I find that, well, I know I've been discriminated against.
Are you a white person, sir? I'm sorry.
Yes, I am.
Okay.
Yeah.
So I think the issue here is, I mean, again, people can experience unfair treatment at many points in their lives, but I think the point is that in the case of racial discrimination in health and racism in health, we're talking about situations that go transgenerationally, that we have conditions that I was mentioning at the beginning of the show in terms of what conditions are when people are even forming in the womb, that you have something happening from early life onwards, that it's cumulative and building up over time. And there may be some instances where there are religious groups that live such different, separate lives with issues of religious discrimination, and that translate into there being very different life circumstances. Some would argue, for example, that that's an aspect of the caste system in India, and where that virtue of complete separation of lives and ways of living of the different castes is a form of discrimination that resembles, ultimately, in a sense, racial discrimination, because there's also very strict laws on who can have children with whom. So it's important to think of these things in context. The occasional time of getting cut off in a car when somebody takes your parking space, or occasional acts of rudeness, is not the same as chronic everyday exposures to the realities of racism, not only in your life, but also in the lives of others that you know, or that the larger community with which you identify. So I think it's very important to be careful about making comparisons of racial discrimination to other forms of discrimination. Each form of discrimination has very unique aspects. That said, what I think is a very important point is that anyone subjected to living under those kinds of conditions would be at increased risk of health. So that becomes the important point to keep in mind. And the question is, what are those conditions? And as I said in the research that we've done, back to the question on preterm delivery, is that the sets of exposures that come with that kind of relentless exposure to everyday racism cause harm to people who experience that. Put anyone under those conditions, and they'll have adverse health outcomes.
We had someone call in at 111. I just wanted to clarify. you said that there were a lot of systems of oppression operating on the planet currently, in addition to the system of racism, white supremacy. Do you believe the system of white supremacy is the dominant system of mistreatment on the planet currently?
I believe it is one aspect. I would not reduce all international relations to a question of only white supremacy.
Right, that was not the question. The question was, do you think the system of white supremacy is the dominant system of mistreatment on the planet?
I don't rank them in that kind of way. I think of them in interconnected ways, so it's difficult for me to answer your question on your terms.
Okay. You did say the white people who practice white supremacy dominate economics, correct?
Within the United States, absolutely.
Worldwide.
And the United States occupies a particular position in the economy, but the United States economy, as we well know, is also in a complicated situation, and it's important to be looking at what's happening in the economies in China right now and other countries like Brazil as well. So I think that these questions get a little bit more complicated. And again, these become broader questions which are interesting to discuss, but I'm hoping to stay right now to the questions of particularly how these matter for health.
Okay, I think that's very important for health. If white supremacy is the dominant system worldwide, dominates economics and all areas of people activity, I think that is dominant and relative to health of everyone on the planet, including non-white people and white people. 111, you have a question?
Yes, I do have a question. It's a two-part question. It would start with, isn't it a basic principle in medical treatment to treat those who have a problem medically, to treat those who are most in need first, and to give them the most help? For instance, you can see that in any emergency room or at any emergency scene. I think that's a yes or no answer.
One would like to think it's a yes or no answer. It doesn't always work out that way. So, and again, I'm not involved in medical treatment directly, but unfortunately, that's not always the case.
True, but isn't that the basic?
Yeah, the basic principle is that people should be treated for whatever the conditions are that they have. But as we know, all
that's not what I said. That isn't what I asked. What I asked is, isn't the basic principle, or isn't the basic objective for treatment, when many people present themselves for treatment, is to make sure that the persons who need the most help get treated first?
If you're talking in an emergency room and there's triage going on, presumably that's the case. That I believe is the principle, but again, I have not studied emergency rooms, so I think it's very important for me to be clear. I think that what you're saying makes sense, but I also am conscious that there is work that has been done that shows that that's not what always happens in emergency rooms. So there's the principle and there's the reality.
I think, yes, that's true. I think we're talking about shoulds, however, and it strains credulity for me, for you as a person who studies medical practices, to not know what I know simply as a patient. When I have taken my offspring or when I have visited emergency rooms myself or urgent care, there are signs all over the place telling the patients that they will be treating, that the emergency room or the urgent care facility will be treating the persons who are most in need of help first. So it's great credulity for me to believe that you do not know that.
No, excuse me. Let me just clarify. One, I think what you're saying is correct. Two, I also think it's really important that when you talk to someone who is doing research in an area, that they're clear on what they actually have personally researched and what they are aware of but have not themselves researched, because too many scientists claim expertise on topics that they actually have not studied. So I have colleagues, for example, who study explicitly what happens in emergency rooms. I'm not one of the people that's done that, and they would be able to answer your question in much more depth than I can. I will agree with you, absolutely, that they are supposed to treat people who are most in need. And I also know that there have been abuses of that. But this is not something I have directly focused on in the research that I have done, and that's a really important distinction to appreciate. It's just that, for example, you can have a physician who is generally aware of hypertension but actually knows nothing about treating it.
Okay.
So you want to be clear on what people's different expertise is. I'm not discounting what you know from your experiences going to hospitals. I'm just being very clear that I actually don't study medical practices. I have studied how people are harmed in their health through doing population-based research. And so I think it's really important to be clear on that, because, as I said, there's been too much work that's been done in science where people speak beyond what their expertise is, and that's been very true in the case of scientific racism.
Okay, so I'm going to focus in on the fact that you said yes, that is what should happen. Now, if that is what should happen, if the persons who most need medical treatment should receive it, then wouldn't it be important to know whether or not who is most in need of help as we look around the planet?
There is lots of work that tries to look at who is burdened by different kinds of diseases. So, but who presents to the emergency room will be the people that are presenting to that emergency room. That's a different question than taking a much broader public health perspective of what kinds of societal interventions need to be made in order for people to be able to live healthy lives. And that's a different question than what's happening in a specific encounter in an emergency room.
So you do not define it as an emergency that I've forgotten the statistics that you cited, but you wouldn't define it as an emergency, the increased rates of infant mortality for black babies.
Excuse me, but you're completely distorting what I'm saying. You started your question asking about what happens in an emergency room. I was responding to what happens to an emergency room in a hospital setting.
No, I did not start my question that way.
Excuse me, but obviously the work that I do has to do with the fact of bringing to light what the injustices are that are absolutely unacceptable, and I have written this explicitly, and have worked with others, including in organizations, to try to change what the policies are, what the politics are, what the resources are, in order to deal with unjust, unfair, inequitable, oppressive conditions that are harming people's health. So absolutely, that's a high priority. Otherwise, I and many others in public health would not be spending the time that we are trying to work together with communities to address and rectify health disparities. They are a critical issue.
Okay, now I did not begin my question that way. If you play the archives or you play a recording, what you will find is that I did not begin my question that way. I began my question by saying by asking whether or not it was a general principle that the persons who need the most help should receive the most help, and then I followed it with an example about urgent care and emergency. So I did not begin my question that way. I simply clarified the nature of the question by giving an example. Then I believe you did concur with me that as a should, rather than as an is, that is what should occur, that the persons who need the most help should receive the most help.
So what is your question?
Okay. So if you agree with that, then isn't it important to know generally who needs the most help medically as we look around the planet? If that general principle is true, not just in an emergency room, not just in an urgent care facility.
Excuse me, but that's what I've already answered. Public health research is premised on that point of trying to understand where the burdens of disease are, where there is unjust suffering, and what should be done to prevent it. Absolutely.
So you're saying yes.
And this is much broader than just medicine and who medically is in need. Public health goes way beyond medicine. Yes.
I don't know if anyone has brought this to your attention, but one of the ways that non-white people who are focused in on replacing the system of white supremacy with justice can gauge whether or not a white person that they're talking to is also interested in that objective is the clarity and conciseness with which they answer questions. Madam, I suspect that you are not interested in that objective because when I ask you simple questions, when others have asked you simple questions, you have given buckets and buckets of words. I'm completely done with pursuing this matter with you because I don't think we're going to get anywhere with someone who has clearly shown that they are interested in practicing deceit. Thank you.
Just last caller before we wrap up the program. 111. We have lots of ones today. 111. Are you there with a question, comment?
Hello?
Yes, we can hear you.
Oh, no, I was just listening.
Oh. Okie dokie.
Yeah.
Outstanding. That's going to wrap up our program. Thank you, Dr. Krieger, for sharing your information with us today. I learned a ton reading the information and having you on the program today. Is there any current projects that you're working on that we should be on the lookout for dealing with racism and health?
There is active work in the field, but it's going to take some time before those studies are completed.
I didn't hear the last part. I'm sorry.
I said there's active work in the field, but it's going to be a number of years before the studies are completed.
Okay. I guess we will have to stay tuned. Again, Dr. Nancy Krieger, Harvard's School of Public Health, thank you for sharing some of your Sunday afternoon with us. Pleasure to speak with you, and we will be on the lookout for more constructive information on racism and health. Thank you a ton for hanging out with us.
You're welcome.
Right on. Very interesting program. Very interesting program. My switchboard has conked out again, just like yesterday, so I cannot get to anybody who is on the phone line. If you're there, sorry, I cannot get to you. Same thing happened yesterday during the program. I also cannot play Mr. Williams' commercial. Same thing that happened yesterday during the program. I hope the information presented was constructive. Cree, last caller to jingle the program, her program, Counter Racist Evolving Engineer. She's here on Blog Talk Radio. You can check out her program. Very constructive information. Seems like she did not think our guest was constructive or sincerely interested in replacing white supremacy with justice. I hope everyone tuning into the program, you can evaluate based on what you heard on the program if you think she was interested in replacing white supremacy with justice. I will definitely tell you from having read her material, I can't speak to her sincerity, but I can speak to her being informed, very, very informed about racism, white supremacy. Wow, she knows a lot. She's at Harvard, so I guess she's supposed to know a lot, but very informed, very interesting information. A lot of her reports talked a lot about not addressing racism on behalf of the non-white people. If you don't talk about it, if you just are being mistreated and are not doing anything to work against it, that can be really harmful for your health. I hope that's one thing. If you didn't get anything else from the program, at least get that one point. If you're being mistreated, if you're a non-white person and you're being mistreated, it can be really harmful. The evidence would suggest it can be real harmful to not find a way to deal with that, to not find some way of addressing it. That doesn't mean go shout at your boss if it's a white person. That doesn't mean if it's a police officer to yell at them and act crazy, but try your best to find some constructive way of dealing with it. If it's talking to someone else, if it's on a job, trying to find some way of getting assistance that you need to deal with the mistreatment. If it's in some other capacity, finding a way to deal with it. At minimum, talking about it can be helpful. Just keeping it bottled up and not talking about it and acting as if this is just the way things are supposed to be. Her reports, the studies that she'd done, suggest that is just really not cool. Very unhelpful for non-white people. So if that's the one thing you take away, that would be the one I hope that you got from the program. Justice, did you have anything you wanted to say before we wrap the program up?
Yes, I think that she used words that it's like she was trying. I think she was trying to. Because when I kept asking some definitions, she didn't really use the definition that I could understand. And
say that one more time. I'm sorry.
Oh, I said the hard word that I didn't know. I didn't know. She gave the definition, but I didn't understand the definition.
Which word was that? Was that equality or prejudice?
It was prejudice and equality, and I think it was discrimination, I think.
Okay.
And then she kept using words that I didn't understand. And I think she was trying to do that on purpose.
That is...
And some of the people in the chat room, they started, like they said, they started saying, well, I bet she's confusing justice a lot.
Are you in the chat room too?
No, I wasn't. I was just reading some of them.
Oh, okay. Well, that is 2 votes for no. Do not think Dr. Krieger sincerely interested in replacing white supremacy with justice. Again, hopefully you all can check out the program for yourselves and evaluate the information. I hope you'll do that for all of the programs that we have. Listen, come to your own conclusion. That's what countering racism is all about, coming to your own conclusion. Listen to the information presented, see if you think it makes sense, see if you think it's constructive, if it has anything valuable for you, then you can move forward. I guess I would say for Justice and anyone listening into the program, if you're talking to white people and they're using terms that you don't understand and you ask them to explain the term and you still don't understand, ask them to clarify again. That is important, and anyone who is interested in having any sort of truthful dialogue with you, really anyone who is interested in being understood, they will make an effort to explain what they're using. They will make an effort to say, hey, I'm using this word, this is what it means. Does that make sense? And if you say no, they'll try again to see if they can explain it so that you can understand, or they'll use a different word that you do understand. That's what I've seen. I don't think that's asking too much. Anybody that's interested in really having communication with you, they'll do that. So that would be my recommendation for Justice. Anybody listening to the program, talking to a white person, they're using terms that you do not understand, there you go. That's what to do. Just ask them, hey, clarify, and don't be afraid to say, hey, I haven't been to Harvard. I'm not as well educated as you. Just, help me understand so that I know what we're talking about here. No one should have a problem with that. Did you want to give out your email address, Justice?
Justice.asap@yahoo.com.
Go. Justice.asap@yahoo.com. She is a trooper hanging in. She's still a little sick, doing better than yesterday, but she is hanging in, not at her best, to ask questions and to hopefully help us get to justice immediately. Thank you for tuning into the I have favors. Okay. If you're listening to this program, today is November 1st. If you're listening to the program, if you catch this before November 3rd, if you can think of any programs that you've heard of the cows that have specific parts that you think are constructive, that you would like to share with other non-white people, please send them to me. We're trying to make a mix that has different sound bits from different programs that we've had. Any programs that you think somebody said something constructive, no matter who it was, if it was when Dr. Welsing was here, Mr. Fuller, Tim Wise, Dr. Moore, any of the people who've been on the program, if you think Dr. Krieger said something that was constructive today, tell me which program and the exact point in the program, like the time marker of where it's said. If you can do that and get it to me before Tuesday, or Tuesday morning. If you can get it to me by Tuesday morning, that would be great. I'm trying to put this mixed thing together with the help of Back of the Bus later in the week. If you can get it to me Tuesday morning, that would be fantastic. I would very much appreciate it. Would be contributing to something constructive, I think. So any sound bites, just let me know. Make sure you put the time down. That would be fantastic. Thank you, Skydrifter. He is known as Skydrifter at YouTube. He took some sound clips from the program and actually put them on YouTube. You can search his name on YouTube and they'll pop up. Appreciate the support. I'm glad you have found some of the programs to be constructive. Codified Games as well. Thank you for listening in consistently. And again, happy birthday, Christy Graham. Right on. I hope you're having a wonderful birthday, November 1st. That will wrap. Oh, my God, I got a Dr. Kevorkian. I forgot. Anybody, if you listened to the program yesterday with Dr. Kevorkian and Khalid Patterson, if you listened to that program, Racism in Film, I enjoyed it very much. Maybe it wasn't constructive, but you can check it out for yourself and decide. We were talking about racism in film. Justice was not feeling well, and she was not able to hang in for the broadcast, and we said we were going to try to think of some films, kid films, that have racism, white supremacy. And Dr. Kevorkian, he emailed me after the show. He said, Inspector Gadget, the movie. He said he thinks that is a great example of racism in a child's film. And he said that Matthew Broderick is playing Inspector Gadget, and D.L. Hughley is the voice of the car that Inspector Gadget drives. That was in the email that he sent. He said he thinks that would be, in his words, he said he thinks that would be an excellent example of a kid's version of Driving Miss Daisy. From Dr. Martin Kevorkian. He emailed me yesterday after the program. So there's one if you want to check that out. If you have kids, maybe that's one you all can watch together and make your own conclusions about what you think is going on there. But important to know, D.L. Hughley is the voice of the car in the film version of Inspector Gadget. There we go. My apologies, Mr. Williams. I was going to play the program. My switchboard got messed up. And anybody who called in who wanted to get a comment in before the show ended, it's not my fault. The switchboard messed up. So you can blame Blog Talk Radio. We'll be back on Thursday, November 5th. We'll be back with Norm Stamper. Norm Stamper, former chief of police in Seattle. He is a white person, I believe. He talks extensively about his time as an enforcement official, both in California and here in Washington State. He talks about the rampant amount of racism that he observed as an enforcement official. His book is called Breaking Rank, if you want to check it out before or after the program, Breaking Rank. But he'll be here on Thursday at 1 p.m. Eastern, 10 a.m. Pacific, early program. But that's Thursday. Should be very interesting to hear a former enforcement official talking honestly about racism practice in police departments in different areas. So check that out. Thank you for supporting the program. I hope it has been of some constructive value. Justice and I will be back. She will hopefully be 100% by the next time we get on the program. And hopefully we'll have a brand new puppy, Jasper Indigo. It'll have two names maybe. Jasper Indigo, the brand new puppy. Thank you all. We'll be back. Our email, justice.asap@yahoo.com. The show clips. If you want to email me the show clips, you can email me untiljustice@gmail.com. If you want to send me the clips, I need them by Tuesday morning. Untiljustice@gmail.com. I would really appreciate it, anybody, if you could pitch in with some sound clips. Anyway, Gus T Renegade and Justice, hoping it has been constructive. We will be back on Thursday, November 5th. Thank you for listening, and hopefully you'll be doing something constructive in the meantime to work against white supremacy. C.O.W.S. signing out.